afternoon. Guests, faculty members, staff, and enthusiastic participants. On behalf of the organizing committee, it is my great honor to welcome you all to the International Politics 2025 hosted by A.B. Shetty Memorial Institute of This year's symposium is held under the banner of the Professor Dr. Shetty Colloquium. The theme Innovations in Conservative and Economic Chemistry, a paradigm shift in clinical protocols. We are privileged to have with us a gathering of academicians, researchers, clinicians, and alumni who have been pioneers in advancing the science and practice of medicine, who continue to inspire the generations of professionals. It is a privilege to introduce the chairperson of today's session, Professor Dr. Darshana Devadiga, Professor of Chemistry. With deep expertise and dedication to clinical practice, teaching and research, she continues to inspire the generations of dental professionals. With great honor, I now invite Professor Darshana Devadiga to kindly take the stage, introduce the moderators, and officially commence them.
Thank you, Dr. Start. We have the moderator for alumni institute, Dr. Lavanya Anupula. She is GDC Bangalore and Conservative Dentistry postgraduate 2008 batch from ABCD. She experience of 8 years. She recently completed PhD from Savita University in the year 2024. Currently the professor and head of Hospital Network publications and research projects. And she has also contributed a chapter in the textbook Endocrinology by Dr. Keen interest in updates and she continues and welcome to the A.B. Shetty Dental back to our department. Glad to have you with us here. The other moderator for the symposium is Dr. Megha Chetan, 2004 graduate of BDS and 2006 graduate of Dentistry and Endodontics. 19 years of teaching and she is currently KGF College of Dental Science Scholar and has presented numerous papers, research and publications to our credit. Welcome back, Megha. Glad to have you here. Now, Dr. Reddy, I think persons and the panelists. We have Dr. Hiresh Shetty, who is also an alumni of our postgraduate program, and he's come from Mumbai. He's a faculty in GDC Mumbai. Dr. Arvind is a 1994 batch PDS alumni of A.B. Shetty, and currently he is in Chennai, and he's a very prolific person in various associations holding various posts to his credit. I ask Dr. Chetna, Dr. Lavanya and Megha to give a brief introduction. Let me just finish this.
Good afternoon, everyone. Thank you, ma'am, for this introduction. So it's indeed a pleasure for both of us and an honor to be moderating this session. We welcome you all to the symposium on innovations in conservative and endodontic dentistry, a paradigm shift in clinical protocols. So we have today with us some of the finest clinicians and academicians to share their perspectives and expertise and adding a new dimension on how we practice endodontics in the present and the future. So before we move into our lectures, a short introduction about our panelists. Our first panelist, as ma'am mentioned, is Dr. Hiresh.
Dr. Hiresh is a highly respected academician with a strong background in conservative dentistry and endodontics. He completed his MDS from A.B. Shetty Memorial in 2006, followed by a PhD from the same institution in 2020. He is currently serving as an additional professor at Nair Hospital Dental College, Mumbai, where he continues to contribute to academics. Dr. Hiresh has been guiding young minds while also advancing this specialty through his work. Please join us in welcoming Professor Dr. Hiresh Shetty.
Our second panelist for today is Professor Dr. Arvind Kumar, who is an accomplished academician and clinician with over 21 years of teaching experience. He currently serves as professor and head at Raja's Dental College and Hospital, and also as a consultant to the Nuclear Power Corporation of India, Kudankulam. Dr. Arvind has contributed extensively to research with 38 publications in national and international journals, and also has been a distinguished speaker among many platforms. He is also a recognized PhD guide under Tamil Nadu Dr. MGR Medical University. Sir is actively involved in professional organizations and served as Joint Secretary IACDE. Also is a recipient of the Masterclass Award from the Conservative and Endodontic Association of Tamil Nadu. We welcome you, sir. So continuing the scientific extravaganza from the pre-conference sessions day before and yesterday's table clinics where the students showcased remarkable scientific depth and innovative thinking, today we shall continue the journey with a new added dimension. So our first speaker for today is Dr. Sonali Kapoor. Ma'am's lecture will be on imaging the invisible CBCT insights for endodontic success. Dr. Sonali Kapoor is an eminent academician, clinician, and leader in the field of endodontics. She is the Dean and Director of Postgraduate Studies at Manubhai Patel Dental College, Vadodara, where she also serves as professor and head of the department. With over 2 decades of academic and clinical excellence, she holds several prestigious positions, including faculty dean and academic council member at multiple universities. Dr. Sonali has a prolific publication record, editorial responsibilities, and also maintains a thriving private practice in Vadodara focused on endodontics, aesthetics, and implant dentistry. It is indeed our honor to welcome you, ma'am.
Very good afternoon to everyone. So thank you. I thank A.B. Shetty for giving me the opportunity. There is a slight change, so today I'm going to talk on the protocols of CBCT. So here I begin, and I bow to Dr. Suresh Chandra, who was the HOD at that time, and the symposium is also dedicated to his name. As you all see here, CBCT is nothing but cone beam computed tomography. It actually means that in a 2D, what are we doing? We are actually compressing a 3-dimensional image into a 2D and visualizing it. So what actually happens is here that we are unable to see the buccolingual aspect, and most of the vision is through the mesiodistal is what we will see. So this technology technically has evolved in times to come, and in certain ways changed the way that we're looking at endodontics. So my presentation would take you through these changes. If you see here, first of all, we really need to understand what are the shortcomings of 2D. That's fine. The shortcomings of 2D are basically what happens is there's a lack of information, there is a superimposition, and there is spatial inoccurrences. So what do we understand by that? There are certain anatomical structures which are actually overlapping on the roots, which are not visible to us, and this leads to insufficient information on a 2D radiograph, which is going to affect our treatment and all our diagnosis. Another aspect which is very, very important and what all of us need to understand is anatomical noise. So 2D has something called as anatomical noise. Now this anatomical noise is something which differs from a person to a person, because it totally depends on the amount of the mineralized and the demineralized bone ratio. So if there is suppose it's a small size lesion, 2 millimeters, and if the lesion is in the cancellous bone and not passing through the cortex, it will not be visible on a 2D image. But if the bone is very thin over that 2 mm lesion, especially in the anterior area where the bone is very thin, that 2 millimeter lesion may be visible on a 2D. So what happens is a small size lesion is not visible on a 2D because it has not reached the demineralized and the mineralized bone critical ratio. So this is very, very important for us to understand. The second thing is the same 2 mm lesion may be visible in the anterior maxilla, and the same 2 millimeter lesion may not be visible in the mandible, because of the position of the lesion. So this is very important for us to understand when the main difference between a 2D and a 3D. What actually a 3D does, or what actually a CBCT does, it actually allows us to overcome the shortcomings of the 2D and allows us to actually visualize the tooth and the anatomical structures around it all in a 3 dimension. Especially the case in endodontics. Why is it so important in endodontics? Because what happens in endodontic therapy is that we are actually doing at a microscopic level nowadays. We are looking at very tiny things, and the planning also needs to be at a microscopic level. So this is what we need to understand. And the 3 planes are the coronal section, the axial section, and the sagittal section. Now, what happens is, where do we use it? How do we use it? So we really need to understand that in a clinical situation, CBCT is just a help. It's a part of the puzzle that we are solving. So it is not possible to only make a diagnosis or a plan depending on the CBCT scan. We actually need to understand what are the clinical conditions, check properly. So we need to understand that the radiography and the clinical go hand in hand to reach to the best of the diagnosis. Another important question which comes to our mind, which mostly of the patients, somebody asks, that what is the kind of exposure that you're going to undergo in a CBCT? It's very common. If you ask a person to go for a CBCT scan, he or she is going to ask you the question. So you need to be aware from the endodontic level. So these are the studies that I've quoted, and what we really need to understand is that CBCT exposure is equivalent to 2 or 3 periapical radiographs. So usually that is what is the protocol when we're doing a root canal. Take 3 angulations. So there are times where you may actually need a CBCT. So it is the data says that. The next thing if you understand is that the radiation in a 3-hour flight, CBCT has lesser radiation than a 3-hour flight also. Now as far as endodontics is concerned, as I already explained to you, we are working in a very, very narrow area. So there is something called as a FOV, field of view. So when you're doing implant dentistry or we are doing other diagnostic value, it's a higher FOV. So as far as endodontics is concerned, we are having a very less or a smaller FOV. What is the advantage of that FOV? What's actually happening is the smaller FOV collimates the beam. So there is lesser radiation which is required to make an image, lesser anatomical structured cover, hence less radiation is absorbed. So that's the whole idea. For endodontic work, we require a very small field of view, but we require a higher resolution. So that is the main difference or the change in the protocol that we're looking at. Of course, we are going to be in alignment with the protocols that follow as low as reasonably achieved. So this is very important. The radiation, we are not going to do it for each and every case. There are certain guidelines which are laid by American associations, even Indian associations and the European. So there are different guidelines which are based, like why would you require a CBCT? So I'm just going to give a brief of what is the help that CBCT does. So the first help here is what I explained to you is, it is used in pre-operative diagnosis, which is very, very important for us. So basically, the main indication is that when you're not able to make a definitive diagnosis on a 2D, when you're confused, when the clinical signs and symptoms are not aligning with the radiographic findings of a 2D. So when you're not sure about a 2D image, it is mandatory to go for a 3D image, because the moment you go for a 3D image, things would change for you. So I'm just going to give a few examples of cases that we have actually published, and I'm giving it with scientific data. So if you see here, this is a case. This article has been published in JCD long time back. So history of trauma, and if you see very carefully, is a sinus tract and there are 2 teeth involved here. But the issue here is, if you see very carefully, on the central incisors, they appeared a lesion around about 1 or 1.5 mm. So there was a slight shift in the 2D, and what we realized is that there was a shift in the image. So the tooth were necrosed, but what appeared to be a resorption lesion was actually not a resorption lesion. Hence we decided to go for a CBCT. So what you see is in a CBCT is that the CBCT gave us that there is no lesion whatsoever, resorption on the tooth. Actually, the diagnosis is canalis cyanosis. That is a physiological structure starting from the nasal to the palatine. So this is a kind of preoperative diagnosis which will help us rule out that this is not a resorptive pathology. So the treatment plan definitely would be a root canal therapy, but it could be a very predictive one, right? So this is how it has helped us. So next case that I'm sharing you is, if you check the radiograph of the maxillary molar 2-7, on a 2D there is a radiographic lesion, but it's not so clear. So in this case, the signs and symptoms of the patient were not matching with the 2D image. Hence, we decided to go for a 3D scan. So what you observe in a 3D scan is that there is a crack there. So hence, in this case, probably the tooth is not treatable. So the reason I'm explaining to you is, from the beginning we need to understand that there is no time, we do not waste time doing the therapy. Also, we do not waste the patient time and economics. If we are very clear to begin with in the treatment plan, it would help us and save both our and the patient time. Now, similarly, this kind of a case. So this was in the department, and the history goes that single visit endodontics was attempted and the file broke in the finishing stage. So now we are perplexed. These are the questions what a general dentist or an endodontist would keep in mind. So which canal is the file fractured? What is the size of the file? What is the length of the trial? And what is the treatment protocol? So it's very difficult to actually plan a treatment protocol based on a 2D. So hence CBCT comes to the rescue. So these are the pictures, and these are the planning what we actually did on the CBCT, and this is the treatment plan. So the plan here is, if you see very carefully, in this we align the tooth to the long axis of the scan, we align the root to the long axis of the scan, and we align the instrument also to the long axis of the scan. Please mind you, there are three things which we want to align to the long axis of the tooth, because the file is fractured, it's in the middle third, it's in the mesiolingual canal, and there is a confluence. So if you see all the three things together, based on this, you need to make your plan. So the plan in this case would not be retrieval, rather it would be continuing with the root canal. The reason that I am explaining here is to you, the file is broken in the finishing stage, A. The second thing is here that since it's a confluence, there is a patent canal which is beyond the instrument. So we can do instrument from the mesiobuccal side, and we can easily clean the apical part. The third and the most important thing here is to understand the size of the instrument. It's a pretty large instrument. It's not a very small instrument, so it's not very easy to remove. You will actually require loops and ultrasonics. And if you check very carefully, it's very close to the mesiolingual root. So there is a full chance that you may create a perforation there. So there are times where you really need to do a micro level analysis to come to a conclusion how CBCT is going to help you. So in our continued quest to solve this issue, we did a study on second molars, and we published it also. So there are two canals and there's a very common confluence. So the inference of this study was that which canal to treat? In a mandibular molar, second molar, it is easier to treat a mesiolingual canal rather than a mesiobuccal canal. So all of you please mind that whenever you're doing a second molar, please treat the mesiolingual canal first and then go for the mesiobuccal. This comes to the diagnosis. The next is micro-level planning. There are calcified canals, there are anatomical variation, curvatures, pre-surgical endodontics, resorptions, complex cases. You really need to think and make your plan. So here the CBCT kind of helps us. So this is a case of a bifurcation. It's very typical on a 2D, you would see that the canal is fainting or it's not visible in the apical 1/3, a typical square-shaped anatomy of the tooth. So of course there is a bifurcation, but it is very difficult to tell that how are you going to approach the bifurcation. from where does the bifurcation start? Does it start from the coronal third, middle third, or the apical third? And again, we have CBCT to the rescue. This is the kind of micro-level planning you can do with the help of CBCT. CBCT not only give us the images in different planes, they help us measure also the length of the route, the length of the canal. So this is the kind of, evaluation you can do on a CBCT. So based on this, you actually know that where would you probably find a canal from the coronal to middle third. So this is how probably you make changes in your plan. So now coming to curvatures, as I told you. So this is another case of a second premolar. It has S-shaped curve, double-shaped root curvature. So there are issues here which one needs to understand. It's a pretty complex case. So what do you decide? Which canal to treat first? There are two canals. There is a palatal and a buccal canal. But because of this complex anatomy, as an endodontist, I really need to understand which is the canal I'm going to treat first. So again, there is a CBCT which comes to the rescue. So what you see here in this particular image is that the CBCT gives us information that the palatal canal in this case is much straighter compared to the buccal canal. So it would go in the favor of treating the palatal canal first and then approaching the buccal canal, because it is a 2-1 configuration. They have the same end, right? So we really need to think and work up on the cases to make our life easy. Next, as I've explained to you, there are resorptions. So resorptions is nothing but an external kind of inflammation. When it comes to invasive cervical resorption, sometimes if you see in the picture, it is not very easy for us to detect clinically. So this canine, if you have a clinical picture, you cannot detect it clinically. So but on the probing and the patient symptoms, we had a doubt, hence we went in for a scan. So what you see here is, this is the kind of planning we did on a CBCT. So now what information does the CBCT gives us? It gives us a lot of information on the depth of the lesion, the width of the lesion. A very important information that the CBCT gives us is the position. So in this case, we'll have to do a surgical intervention. So we need to understand that the lesion is at the crest. So it should be visible. So once you open a flap, there should be visibility of the lesion. Then only it will be successful. So this kind of a lesion can be treated successfully, right? So this is how it goes. Of course, and one more thing that we did in this is we changed the protocol of the access. The access cavity was taken from the cervical area. We did not go the conventional way. So the point here is you have to make change in protocols because of the micro level of planning, and this is what we achieved. So there's a lot of slight bone cutting, you have to curate the lesion, degranulate it, and then only the lesion becomes visible. So that's the second application, helps us in treatment planning. So the third application, and the most important application, is that probably you can also integrate CBCT with the other technologies, scanners and 3D printers. So you have to take use of technology, what you have, and take your treatment plan to a next level. So we have this study already done before, especially used in surgical. So CBCT is extremely useful as far as pre-surgical planning is concerned. Endodontic surgery is what I mean. And we've tried to incorporate in the department, it's a copyrighted model that we made of 3D printing, which is actually for academic purpose and which helps the PG students do endodontic surgery very predictable, minimally invasive. So this is the case, and it's due to come up in the next issue of the Saudi Endodontic Journal. So this is purely surgical endodontic. The reason that I put it, it's just to understand that the protocols change to the next level. So what we've done is, the problems we had in surgical endodontics was suctioning, retraction. So we made a 3D printed device. If you see, it's kept in the mouth. It has those retraction, it retracts the upper lip. It gives us, yeah, it's a little complicated to understand at this forum, so it's just, there is an incision line there, and we planned the excision site also. 3 millimeter. So when we cut the bone exactly at 3 millimeter, we cut and this is what we get. So this is a copyrighted design using 3D printed model. So when we try to innovate and go next. Suppose there is a lesion here. Now in this, the canal is totally calcified in the central incisor. So we cannot do a root canal here. But the size of the lesion is very small. So what we try to do is we try to use a trephine-based technique where we plan the trephine position on the CBCT, we design a 3D printed model, and we kind of remove the bone and resect the 1/3 of the root at the same time. So these are the innovations, what you can do with the help of technology and the use of knowledge, whatever you have. The next is, there are times when there are things where this is out of the box case. So it's a history of a trauma, avulsion, and if you see that atypical anatomy. Now, if in this case, if you're going to go from a palatal view, things are not, make the access from the palatal, it's not going to work. So what we did is, again we have CBCT to our rescue. So if you see here very carefully, we have planned the entire case on a CBCT, and here it is for you. So what we do here is that instead of taking a palatal access, we actually check from where there is entry inside, and depending on that we design from where we are going to take a access, and the access was a labial access specifically, and we actually knew where to go. And this is what it is, right? The access was where to have the access cavity was totally designed, it was minimally invasive, and this is what you can achieve with the help of technology. So we really need to, use our brains, and in which direction we are going, plan it. So another application is the assessment of healing. Very important. Because sometimes in endodontic therapy, you're doing a multi-visit procedure. So sometimes when the lesion is very large and probably you want to go non-surgical, you don't know when do you want to, when are you going to complete your filling. So this is a case from a COVID time. Patient didn't return for a year. And see this. This complete healing. So sometimes when a patient comes to you for 1 year, you don't know what's happening inside. So CBCT is again come to our rescue here, and we see the amount of healing present here, and of course you can finish the treatment successfully. So this is another case, and this had come to me like 8 months back, and on 15th August I took. So if you see the amount of bone destruction in this case, and we repeated the CBCT after 8 months on 15th August, and this is what it is. It's a completely healed lesion. Of course, we removed one of the central incisors, curated the lesion, that was the plan. And now we can successfully complete the case and probably think of a prosthesis because it's a healing lesion. So these are the things what really need to understand how you can use CBCT for your endodontic. These are the publications that CBCT based we've been doing for the longest. And I thank you very much for a patient listening. I'm trying to keep to my time. I thank the organizing committee and of course A.B. Shetty Dental College, my alma mater, for giving me the opportunity to share my thoughts on this particular topic. Thank you very much.
Yeah, thank you, Dr. Sonali, for a brilliant insight on CBCT and how CBCT provides a new dimension in diagnosis, planning, and healing assessment. Panelists, do you have any questions? Audience, do you have any questions? Any questions from the audience? No. So, we carry on to our next speaker.
So we have just learned how CBCT helps us to